Some distant, sophisticated, and observant alien race may soon decide to study us before they bump into us in the void between the stars. No doubt, they would send for this task one of their best social scientists, and no doubt she would be surprised that the creatures who are about to step into the stars still fight among themselves and watch a shockingly high volume of TikTok. But she might also decide that these facts, though interesting, do not define us. Seeing that there are still political divisions amongst us, she may decide to settle in the most formidable and advanced of those divisions, or country as we call it. And somewhere in the United States, she might decide that if she wants to understand us, she would have to study what we value. She could be blamed if she defined that as the effort where we spend most of our collective resources. Even a cursory search of our collective consciousness, what the locals call the internet, would yield that we spend more on healthcare than any other endeavor. At this juncture, she might be puzzled. The definition of health, as our internet tells her, is a state of physical and mental well being and not just the absence of disease. And the definition of care is the provision of what is necessary to maintain a thing. The source of our confusion might be that we spend nearly one fifth of our total resources, again by far more than any of our other endeavors, on something that we have mislabeled. Because she would see what is plainly apparent that the US doesn't have a healthcare system. What it has is a disease modification and control system. The numbers tells the story. 37% of our healthcare spending is on hospitals, 24% on physician services, 12% on medications, and the rest mostly on nursing homes, dental care, and medical equipment. That is, nearly 100% of our healthcare spending is on disease identification and management, and virtually 0% on the literal definition of health. Let us concede that disease is expensive. Its prevention and management are more definable societal goals than the maintenance of a state of well being. Let us also concede that disease control and modification have something to do with health because the occurrence of disease is certainly contrary to health. So, how is our alien anthropologist new home doing with respect to disease prevention and management? Well, it ranks 48th in the world in life expectancy, 54th in infant mortality, and ranks highest in chronic disease burden. Though more difficult to measure, its sense of well being or its health is defined by occurrence of depression, perception of life satisfaction, access to nutritious food versus ultra processed food, time for leisure activities, time for sleep. All of these are declining. Taken together, the correlation is stark. Over the same period in which the US has spent more than any other country on disease management, its health has declined and disease rates have gone up, which begs the obvious questions. What are the factors that bolster health? Does a decline in health lead to disease? And if it does, can we envision a paradigm shift that leads to a win win situation? A state in which we have the benefits of improved health, leading to a lowering of the incidence of disease and therefore the financial cost of disease. The chief measurable correlation for a sense of physical and mental well being, health, is what has come to be known as metabolic health. The literal definition of good metabolic health is good metabolism, the digestion and absorption of nutrients that promotes a homeostatic state, minimizing inflammatory response. Inflammation being a common denominator in many disease states. The primary factors that boost good metabolic health are reducing free sugar intake to less than 10% of calories, a reduction of highly processed calorie dense food leading to a lowering of body weight, 7 to 9 hours of sleep every night, at least 150 minutes of moderate intensity exercise per week, elimination of tobacco, and a lowering of self reported life stress using a validated scale. Its measures include BMI, blood glucose, blood pressure, cholesterol levels. Now, at this point, you and our alien anthropologists may wonder if we could achieve these secondary measures, improve glucose, cholesterol, etc., through medication rather than the primary methods of diet, exercise, etc. Would the effect on metabolic health be the same? The answer is no, for at least two very important reasons. The first is that the central pathway of nearly all systemic disease is once again inflammation. And while medications improve the numbers, they do not have the same impact on the inflammatory markers that ideal primary metabolic health does. Secondly, improvements in diet, exercise, sleep, etc., produce benefits such as improved bone health, insulin sensitivity, amongst others, which have a multiplier effect on health. The reduction of life stress, as measured by validated scales, reduces the level of stress hormones which carry the same multiplier effect. So, medication is not a shortcut to good metabolic health. She may then ask, does poor metabolic health lead to disease? And further, does our current practice of preventative medicine, which emphasizes medication, work equally well as good health for disease prevention? The answers are unequivocally yes and no. From cancer to heart disease to major depression, the medical literature is replete with studies that show that these disease states correlate strongly with compromised metabolic health. It is also replete with evidence which supports that medication for correction of metabolic parameters is not equivalent to good global health when it comes to disease prevention. This latter reality is also seen in a review of epidemiological literature. It shows that the developed countries with the best metabolic health are among the top in life expectancy and lowest in occurrence of chronic disease. The difference between those countries and the US is the cultural and societal emphasis on good health, not access or use of medication to achieve better blood glucose or cholesterol. So now our alien anthropologists can draw some overall conclusions. Good metabolic health is good health, and there is no substitute for good health when it comes to disease prevention. And at this point, though she is only an observer, she may be frustrated by the fact that our advanced society spends so much effort on mitigating the consequences of bad health and almost nothing on supporting the basics of good health. A general understanding of our society may lead her to conclude that its members do not like collective mandates, that they value their individual freedom to make choices, even those that may lead to disease or death. So, is there a historical model that can be used to effect a cultural change towards good health? Yes, there is. Adult per capita tobacco consumption has declined by nearly 70% since the 1960s. The two main factors were the dissemination of information regarding tobacco's association with cancer and the placement of surcharges on tobacco products. The strategy worked. By one estimate, nearly 800,000 fewer Americans have died from lung cancer alone due to the reduction in smoking between 1975 to 2000. the estimated cost saving approaches $1 trillion. What if the public of this country was educated on what its scientists already knew? That its biggest food companies infuse their products with sodium and high fructose corn syrup, creating, whether by intent or accident, a state that approaches addiction in their consumers. Could there then be a national will to tax these products to discourage their use, as was the case with cigarettes? Could big food be held accountable as big tobacco has been? Could it be forced to sacrifice some profits from products that cause illness to support and lower the cost of low glycemic index, minimally processed foods? Can there be a national conversation that shows the links between sleep and exercise to disease prevention as there had been with tobacco? Can there then be voluntary monitoring of sleep time and exercise to lower health insurance premiums, just as there are voluntary monitoring programs for safe driving that lower car insurance premiums? Is it possible that this cultural shift would create health benefits that were so obvious to so many that the emphasis on good health would become self perpetuating? By one estimate, if the obesity rate in the US was reduced by 10%, if there was increase in the exercise rate by 10%, if an additional 10% of Americans slept 8 hours, and if an additional 10% of physicians screened for and treated life stress, the reduction in healthcare cost would approach $150 billion annually. If these changes came close to the success that the cultural shift against smoking has achieved, the financial, health, and disease prevention future of this country would be, well, otherworldly as compared to the current trajectory. Having achieved this clarity, it is time for our anthropologist to file her report and for us to get to work.